admission into the VA, where I spent the last 15 years in specialty care, family, including critical care, cardiovascular infection disease. We currently provide advanced cardiac care for complex heart patients for VA. It also has with numerous complications, or maybe for device management and device management. It is also, we also serve as the BIS and UND academic details with experience in cardiology and the world.
Thank you, the introduction to what it's very theory. It's kind of a very intriguing in that you have simply that in detailing for the past 3 years. We've focused in on heart failure 3 years ago, hypertension, then progress into the composite diabetes, some of the quantification scores. And this year is really kind of focusing on CKD with or without diabetes. So what is academic detailing? Basically, when they initially came up with like, well, a guideline published, how long does it take to fully agree with clinical practice? About a decade. So through your Harvard decided how can we optimize this to kind of shrink this down, and that's where the first academic from the program started. But eventually, small group interactions, number 1 to 6, ideally one-on-one clinician, has to be whether your barriers in clinic, our specific medication get utilized, just so that we have the most robust and current information. It is like your file books now, it's graphic, a little bit older, but 2017, that's not doubling about every 7 days. Now it's much lower in a few days. And we do kind of have this renaissance for gold relation medicine again, to where it's almost like having a teach. If you're starting to look through that database, it's about 5 years old, probably outdated at that point, just because they're new norms and the last reason I make this profound amounts of positive benefit for patients, and just really is a more of a earth shattering on relative risk reductions. And then if you're curious about these stats, look up the private sector, closest comparatively science liaison, they're the pharmaceutical industry, where they'll be a subject matter expert on a specific therapy that they will have a field of listening for, but we focus on pushing me into the compared to most of the current guideline, here's the recommendation, how we need to create that. So as I mentioned, we had a lot of focus initially on the effectively last year, on diabetes, we transition those are the biggest drivers of CKD. So that's why we're going to be clear up in both of those. And of course, anytime you come and talk to this facility, we also going to be outlining things that have gone exceptionally well. So look, one of the last big projects we focused in on is across all 8 nodes, and we're really trying to focus on hypertension management. And you can see here, this is your specific data. So you see the dip there, and take it back farther. There was this kind of balance around maybe 60-65% of patients having control of blood pressure. And the metric is relatively generous. It's not a less than 180, it's less than 130. Or being with primary care and different leadership and all the work on the pathway and including fixing system errors. You see you guys have done exceptionally great work of that translate to patient care. So this is a cohort roughly about 10,000 patients. So you now have 10,000 more patients having that all the way on the management, therefore less be a very similar means. So that's a great job. Now, trying this sheet is GDP is a very big problem. It's 20 times more prevalent than cancer. It impacts almost a million patients worldwide. And one aspect of the 1 in 10 of the general population has CKD, and that's a warning. Now I'll come back to that word warning in a few slides. I'm sure Spero projecting the 50 college deaths. So we have a worsening without profound changes in therapy. This is continues to get worse, which fortunately do have profound changes in therapy. So what is the problem we're trying to address or discuss today? It's really, the diabetic population of about 500 million patients worldwide. The vast majority is type 2 diabetes. So 4 out of 10 of those individuals have had diabetic kidney disease. And you take that to, okay, what percent of patient is driving the CKD overall? About 50% of those in CKD originating from diabetic kidney population. So we want to try to really focus in on calculating optimizing. Well, this graphic is kind of interesting, right? If you look, those individuals that progress to kidney failure and die from a kidney etiology, about 10%. That doesn't mean they're doing a great job of preventing. Actually, what's happening is 90% of patients are dying cardiovascular. So over the last decade, a lot of the management and focus has been on addressing the need for the cohort of the need to address cardiovascular outcome in addition to the nephrology outcomes from working to prevent patient progressing failure. This graph right here really stresses an outline of there's industry risk factors for mortality. It's pretty high threshold. If you look, think if you GFR like 60, it's less than 60, that's in respect to mortality. You're in outbreak frequency ratio, if you're greater than that 20 to 10 milligrams per gram, also in risk factor for mortality. That's this graph will show. So if you look at the age of all mortalities, who goes from right to left, as you increase, right, as your GFR decreases, your mortality increases. And the urinary ACR as it increases, so the more non-urinary you have, the higher inflammation. So now I mentioned the warming earlier, 1 in the general population has KD, but upward of 90% of individuals receive KD. So there's not like really a specific symptom or easy way for a patient to self-identify as very insidious onset. It's not like high blood pressure, a patient might feel unwell with the retail setting, get blood pressure checked very easily. You can do it at home. You can quickly discover when he's going to stop a condition, high blood pressure. Not the case with the baby, 90% of patients don't know. So they'll know that as their provider that assistant to the treatment. So how do we identify these patients? The primary drivers. And this screening is very specific. It's some form of renal function test. So something to GFR of MA, N12, step and then also having a urinary albumin ratio. Now, if you prefer urinary albumin ratio, you can utilize it. The reason why UHCR and we get over it is because it's more sensitive to FNP stated earlier in usually but regardless, you can utilize both, and that's what the people talk on the top line of this graphic. The highlighted section is really just outlining that there is a priority of response, and some depending votes. They are listed as the further, and then second, and third is down. Now, I'm bringing up the white person. Anytime someone's ever come to me for the last 20 years, it's like, John, we need you to see more patients, we need to expand these days, we need you to see people improvement to address the issue, we need to include point on the investigation. I would like to look at those recent objectives and that's why I say more often than not, it's a little phase that we need to do it, and you got to do today. Who's telling day what to do it, them is on the day. So it always can make you like you don't find that right? So I'm very transparent to the point of fault. So let's driving this specific discussion today. Earlier, we're looking at specific metrics, right? So I have component plan facilities have scorecards. And if you're looking at scorecard, what's right? The one that's big 5 cell metrics for a facility. This is ENG 9-1. Fancy way of saying there's several aspects that go on. So it allows senior leadership, like visit level, maybe level leadership to compare facility A with the facility B, which one providing the better quality of care. So that's what these numbers like metrics look at. So overall, we can see we're doing a pretty good job here at Boise for most metrics. But then this kidney health metric on the bottom, you can see that we have some room for improvement where it's a little bit below the contact convention. So that's where the request is coming from. Mentioned earlier, academic detailing our job is we're reviewing individually, but also try to remove barriers from the system in order to make sure that you're getting adequate in data capture for all the trade workers. One of the areas we identified for patients with like diabetes in labs need to have like mandatory, there's at least minimal 3 laboratories, and that's ordering a lot of different methods and pathways. And it does vary by site, like how those papers are proposed, clinician driven versus, support staff driving some annual labs. But we went ahead and addressed that, working very closely with our nursing colleagues. We helped, kind of figure out the pathway. And just by having some small pilot project outreach with individual providers, also trying to fix the systems and leadership support, we do have this nice reversal of increasing. Now, the national cohort's not on here because it's like way up there, 72%. But this shows very nice quick change just by making the system easier to utilize. So like the version is. The one is called dive button. I don't know if it's frowned upon, but it was not approved. So what it involves the EM labs. You do have it in your outpatient hub as well as under immigrant. So the combination for outpatient labs and immigrant. On the discussion on leadership about what should be included, because every condition and patient has no specific different class needs in that workers. So the bare minimum that is mandatory or minute privileges, like any diabetes class, A1C, urinary ACR, or anything. So those are three that are in specific order tree. And then we move those at least annually on a patient that I believe. So now, kind of the audio aspect, I'm going to turn over to the nephrology expert.
So then this vote says, in my experience, it used to make sense, but everybody is including in my own stuff. The gate are in arterial here. Now. So, in most cases, especially diabetes, because the difference are so much hyperfiltration, which is a really just pathological mechanism by which keeping good answers. Diabetics. They are in arterial dilates. So if you look at the picture here, the A turn is always smaller than the B turn. And patients have a real serious, but the was down in the urine is it increases sodium reabsorption. So as sodium is reabsorbed, we activate that as a signal to the A-turn arterial to dilate. And it's doing that because it wants more sodium delivery distally because it's telling itself, so wait, it's less sodium delivery. So I must have decreased blood flow. So it dilates the A-turn arterial. So as it dilates the A-turn arterial, it increases hydrostatic pressure inside the glomerulus. And when we think about Flummon's capsule on the outside of this, it causes hyperfiltration. And then on the A-turn arterial, the JG apparatus produces rain. And then right in that line causes fatal constriction of the B-turn arterial valve. Additionally increases intraglomerular hypertension, which also worsens hyperfiltration. All of that cells for sandhill cells. Wow, I'm gonna lay down extracellular needs. Increased fibrosis and inflammation by increasing by. So it's a very inflammatory process. These inhibitors and hydrochloride. And hydrochloride by blocking, by increased like blocking glucose reabsorption and sodium reabsorption. it increases, it decreases, sorry, the regular hypertension, and then it was something that actually, obviously diet, and material, and thereby decreasing, the rate of hypertension. And so these drugs are critical in our patient. And then it's the rate of question.
Okay. So, the non-nephrology expert of V28 is looked at the graphic here. You have, a APR addressing or something like one for this the problem, where you're essentially two hitters addressing for this big problem. So we would expect a little bigger responses will show you in a few slides. So I want to expose myself a little bit here. When I looked at this graphic in general, the person might saw it, thinking, okay, green means I don't need to do anything. Perhaps the yellow and orange means I'm going to screen these individuals. Red and that probably should treat the patients. That's kind of my interpretation, right? Horrifically wrong, by the way. So that's not how you interpret it. So when I go into the specifics, the nephrologist loves to throw this big hazard ratio graphics like these here. And like, what is the heck is this? I think this is my interpretation. Okay, this is bad. God, very bad. You have 400, 500, 600% increase in death, atrial fibrillation, there's some cardiology stuff on there. So the correlation is color damage. God, that I understand. So, okay. So if we take a patient, let's say something pretty benign, right? 65 EGFR, up in the area, somewhere in the same point. That's up there in the yellow, not too terrible. But this is hazard ratios that are standardized for all patient populations. So your patient in front of you, you don't say, I'm know what the risk of this patient, risk of death is for CKD. So you take our patient up there on the top, or whatever. Anyway, the one on the top one, this is all mentality. If you go to where it's like 65 and up in the area of about 25, that's 1.6 hazard ratio, so 60% higher risk of death than the general population. And you can extrapolate that out. If you look at the red boxes, the very high risk categories, they're talking 5-6% full risk. So that's how these grades to apply it. Therefore, go over this shortly here in order to outline the general pathogenesis. The typical we'll see is we'll have EGFR as other outline. You have that down process. So you have all this invasion, and what happens is you have more knowledge in the area. But the EGFR initially is contained, perhaps it's super therapeutic, and that's the opposite. They're having this nasty progression in the increase in the area, and so the patient gains their EGFR comments, to like 30, which is that biopsy that so this is what it looks like. Not very what the digital looks like. Anyway, this is what it is. Okay. So you see the patient, or by individuals on monitor, you see a patient that comes in and they have CKD, or maybe they just have diabetes. And you do your annual lab, and you're like, oh my goodness, this person renal is at 200 plus. They got that super human index. But then also, if you look at creatinine below 4.5.6. This is actually early stage kidney. So if you want to start treating here, that's ideally where we want to start. So you're seeing something in the diabetic patient, 200 plus EGFR, alarm bells will be going off, kind of something. This is probably what was described earlier, is hyperfiltration in radiology. And where do we typically maybe I have those fields, where would I initially consult no problem for replay? Probably down here. Just being honest. Should probably consult for where starting therapy, but in general, in practice, this is for so now diving into the diagnosis aspects, very straightforward. Not like squishy or dog like over pressures or something like that. It's very very rare. So if it's either the work system code, the individual EGFR less than 50, the more than 3 months, probably the diagnosis is made. The other one is albuminuria. So if you have that 30 milligram per gram for 1 to 2 readings, you can also make the diagnosis. So this is a point where you want to start like initial therapy before EGFR really starts to decline. Now we can kind of pull it all together like my fourth initiative, like how I interpreted the red, green, yellow. Now I'm going to pull it. So the green aspects, we screen all patients. Like anyone with diabetes needs to have a annual screening. That's from the ADA guideline. The numbers are how many times we recommend that patients be screened at minimum. So if it says 4, it's at minimum 4 times a year. Here's what we for that. If you're starting therapy, the patients had an eGFR decline by 30%, you're having doubling of the albumin area, so it was from 30 to 60. You need to start adding on targeted therapies. So you see pretty much every box besides grading stage 3. So the treatment thresholds to start very early, these take fast and close to here. Now we get to my part to go finding medication. This is just a little shout out to my diabetes colleagues. They have the they have the most living guidelines of dates over people times per year. So they outline here as one stress in the bottom. Irrespective of A1C, the patient with diabetes has these conditions. They need to have specific therapies, like methamphetamine or GLP-1, whatever, irrespective. The best example is 70-year-old high blood pressure, CKD, A1C score of 1.8. That individual needs to have actually including the other prevent their depression. That's according to the recommendation. One of the recommendations, total diabetes, does not will have. So take you back a little bit, history. Now it's been 25 years since the last RAS inhibitor products. We've had them out of 19 studies. They're showing a relative risk of about 18%, 16%, 20%. And these are specifically in type 2 diabetics. So at the time that the survey, my goodness, we slowly progression. There was no stopping how this because we slowly progressions. Pretty exciting. 16%, 14%. As of today, it's not that. If you look at the residual risk, that's what all the red lines are for. After about 48 months, 2.5 years, the patients still retain 50% of residual risk of progressing to death or failure. So we make a small approach, which makes sense. Going back to kind of physiology, you're only addressing 1/5 of the problem. So we expect a small response. Now we bring in our rock stars if you look at 2 inhibitors, which if you just look with primary risk reduction, you're looking at somewhere between 30 and 40%. So almost double of what we had with the ACE inhibition. And in general, right, in medical school, pharmacy school, nursing school, just like everybody has the AD mutation on it. Okay. Our SO2 inhibitors are at least double that growth risk reduction as their base start. And this is on top of basically. All these studies require our ACE number based at max tolerated doses and then they're out of there. And each of these outline the ingredients in all type 2 diabetic patients. And they did that with CKD for a third who didn't have diabetes, but they've expanded it out by lower eGFR. By the time we get the kidney, we have 51% patients don't have diabetes. So we have a very broad population for these therapies for addressing it. Now, if you look at residual risk for being, we were roughly 80% just inhibition, inhibition. Now we're looking at right about 15% in the risk. That's profoundly better than we were before, which is why these therapies have kind of taking the still got form. They are growth inhibitors, but they are light and diabetes as well as happens done. So now we get to the foundation pyramid that I think are guidelines. Over the last 30 years, in dietitians start that. Well, dietitians also get. So really, the mainstay has been diet, exercise, like medications. But their base reality ethically failed over 30 to 40 years. So if you have a patient and a diagnosis, you gave I strongly recommended one of the recommendations. For patients with CKD and diabetes, also strong recommendations for those that have CKD and autoimmune area. And then also those that have a lower UTFR autoimmune area. Those are not anything new. Those have kind of hanging around for over 2 years. Now, 3 years ago, when we were really pushing on the heart failure updates, we were saying, well, start actually to inhibitors. You have this potential 30% decline in GFR initiative starting. So lots of advocating about we need to get a renal because they had to be follow up on monitoring for patients on this therapy. However, all the primes actually proved that we were wrong just 3 years ago. That's things repeating that. This class. So there's no need to get a that's actually problem taking the hope double therapies, quadruple ventricle. So in general, meeting group has submitted their manuscript for publication. So the last time it's held was October. So we might have some guidelines coming out this month, but the issue by the end of the year at the pace. And it might, this is forecasting, so it might take a second. Might end up being terrible recovery therapy to see you're going to end up with their cardio, which is very impressive. So we'll jump back into the evidence based opinion. So now we're back to evidence based. Right. So I'll have to use the, oh, what is that? All right, so why do we advocate combination? The number one cause of cessation or discontinuation of RAS inhibition is that paper right here. 67% of the reasons combination is significant on the NARS is like hypokalemia, around both phoenix indication on start with this hypokalemia, the wide ambition. You don't have a synergy. We have this like RAS division doesn't inherit the process. So you have the potassium secretion is inhibited to an extent, so you get an increase in potassium amount. Where you actually think that there's causes of potassium secretion of like person. So period like the example why accelerated, like keep reading, level rate from the slide. SJ2 inhibitor therapy, you reduce this type of anemia agents on the RAS inhibition by increasing the sodium delivery, enhancing potassium secretion, and promoting mild volume contraction and the loss of activity. So really putting those together has a very positive effect. Well, that period right is approved. It is a proven phenomenon that you will, because going back to the pathophysiology, going back to their mind with y'all on the actions. So that's studies looking at can we improve it in a statistical form, right? So they have. So individuals are on combination therapy and have about 14 to 50 years and less chance of having their last efficiency. You just this kind of cut. Now, if you have patients trying to use CKD, their EGFR is like 15. We continue at pace or There's that gut thing, forces and lupus, lupus, part of that, right? But then that's the question is the we should continue. So actual recommendation is we should continue. They looked at the stop base studies where they decide, okay, if the grass condition is bad for patients with low GFR study median was a 13, then patients should have a positive outcome and stop the therapy. If that not, patients progress at a much faster rate. So they came out with this point recommendation that they should continue grass condition or even GFR. That's kind of a counterintuitive perspective. So hyperkalemia is where I've been a lot of my time in clinic, because maybe all my patients are interested of nuclear, phosphoric acid, diuretics, and this sort of a lot of my time. And you can manage the extent through dietary modifications. So this just become in handy. Sometimes it's potassium substitutes like dash, potassium salt, and patient eat like over a dozen bananas a day, large bananas, to get better. Potassium and moderate doses. So you that's okay, I'm a banana, 3 days, also 6 bananas, okay, after that, and then of course, you discontinue the fast. They might still be eating it, and patients struggled for months, by maintenance. Maybe 6, some patient like, and trying to figure out what's going on and talk to them and let's say, are you taking anybody to that's go towards like our right goes in the goal. I just continued 14 months prior. What's going on? Well, yeah, my doctors told me that if I take my water, I have to take this pill to back things. Like that. Yeah. So I mean, it's a surprising how often that patient can still take their tests and say, in total, over and over, they have to take the test and make a part of it. We have things like that, traffic, clear, we can get through this guideline and outline things that already said, focusing on any other means to mitigate the heating potassium binders, which are part of formulary requests, but all those things first. Then maybe a reduction, worst case scenario, patient therapy did that up. Thank you. This graphic specifically is very much shared at a very grand round, so I don't spend too much time on it. Other than our signals and the literature is not very supportive of bacterial urinary tract infection. Now, as John would say, patient that's on therapy won't have a urinary tract infection. It does have a very often. Probably fair to say that have increased rates of bacteria. So just outlining that from studies, the only thing they found was the impact group study, the female population. We did have specific higher rates of urinary tract infections in the placebo. We don't say protective against nuts. But that's the only study that's far as a proven higher rates of urinary tract infections or in the placebo arm. So we can't draw up that. What we can draw conclusions from general and chronic infections much higher rates, potentially with our people higher risk, individuals that are uncircumcised, very large body cavities, origin hygiene for all those risks. So if you're having recurrent, not always systemic body infections, probably complication, maybe consult diabetes, these are some of the elements.
Here it is.
Yeah. Anyway, all right.
You do.
Public medications. I'm going to include this
And I
because
just signed it.
Grandma following the topic earlier this year. Got several questions about the feed and like that, but also the sulfur, CBT, people there. And I was curious about more. You don't answer, but I guess. It kind of interesting more about that or where the is. You give those back to one med school, with pharmacy school, there's a school, they're saying that you increase your patients. And then you put this through this 2017, the cannabis study outlined, my goodness, some patients that increased their patients. They tried to replicate it, they're not able to. Even observation studies looking at routine with digestive ulcers that are infected. They've only had history of infection, not increased patient. So that the I still remove fire alarms when they, so it doesn't not place we can one that. Right? So if you have a patient, but it's based on diabetes. But we goes to greater than 9 milligrams, like 80% that they're going to appear in your song. Right? Like the family that you cells and line the action. We draw something like that. And we can try and follow this with the order to find the meeting organism. Quite native. So anything is going to be control at the baseline, so you're positive there, you're hoping to the next process. So very solidly say it's not increased amputation, it's not compared to using based off of the underlying pathogens we stated after versus. So here's just outlining the potential barriers. For the sake of time, I did include the specific paper looking at it, but they did a study and we reduce general mycotic infection by through counseling. I didn't fall back again, no. However, they found if you counsel patients while starting therapy on good general hygiene, keep yourself clean down there, and you won't have nasty mold and fungus growth. And it's very effective because at 6 months without counseling, 41% of patients found genital mycotic infections. Those who receive counseling, they're only down to 40%. Like I would like to say it just like skeptical, but that's pretty impressive for just saying that. But that could work. Hey, like the shower, not going to do that, but we might have some motor focus. You're to the family with that. Bam! So what happens? We stop there. And we'll stop there. These people stop there. These benefits from part of antibodies is taken. Unfortunately, they do. So we have data from the data of our failure, as well as in kidney, showing that we do lose the part of this. Unfortunately, for heart failure, it's going to happen loss than we use for our renal protection. Within 30 days, the patient had increased hospitalization after stopping therapy. And if you look at the kidneys, a little bit longer, you'll have some protection out to a year, but within 3 months, you lose the vaccine protection, increase protection. And that's just why, oh boy, American College of Cardiology, American Heart Failure Society, and American Heart Association, I'll figure that. I'll say that disruption therapy should be minimized as well as hospital therapy should be taken outside of absolute contraindications, then had one patient at a different site had anaphylaxis to therapy. They kind of didn't believe it, so they reached out like the hospital next to you, which is good way to test it out. And second, anaphylaxis. They got at it as the all right, so we're going to be whole officially based on the literature. The preparing procedure 3 or 4 days is guideline based. I've been evolving because there's one paper that came out, I think it was last month, that's only your questions we should or not. So, but as of right now, the official recommendations are for procedure building 3 or 4 days. Acute here, complicated urinary tract infections. There's a current guidance says if you're on patient, treat for it. You will stop therapy. But between you and your patient, if you have a conversation, you guys decide, well, you want the best chance of recovery, or there's extensive risk, regression, go to the hospital. You want to stop therapy for a week, potentially 3, that's going to be okay. But the literature's on the side is free for application settings. Mid to hospital sepsis here in your and then when it starts. You want that ear retention comes from our urology colleagues. They're probably look up for that. But having good communication of how long the whole important. One big that therapy, increasing mortality, increasing hospitalizations, and the current UTIs. And around, we got this specific guidance from Boise. Basically, finds your breathe and pull a time period. That's happening. Following, especially if they're referral, if your urology going to be infectious disease. So, in our review, we're initiating their basic and our standard care like on the 30 years. 70% feels kind of low. Maybe she had 85%. And you can't get to the 100 URS patients. But those at 90 days. after starting, drop go down to 40%. If you look at like our HO2 inhibitor business, only about 6% of the attorneys started therapy, but a higher percentage are retaining. But I don't think we can stay in the victory that, you know, I didn't sit and retain when it's almost fit. So this is my favorite graphic. I can AI make that. Pretty cool. First version of Spero. So the spider event efforts. We started on HO2 inhibitors, rapid vision. And they're having that doubling out in the area where their PDFR is defining where we go from there. That's when, as of October 2nd, we go to target there. And so what we're focusing on just briefly here is Cadiorenal. It is on the formulary in the VA. Powder looks nice. The bottom is directly snip from the VA via the management. Staffing match management. So the non-formulary right here for you document, actually exactly defining is non-formulary again. There's a check box. They do type 2 albumin area, GFR, and potassium, through patient therapy. Now, there's always discussions of like, well, it's a newer fancy shiny drug, and we use the older drug that may be just as effective. Usually don't get those studies done, right? Because most of our research is funded by industry. And, you know, that's a lot of my information dated about 18 years ago. I was running phase 3 clinical trial about that's like 18 years ago. So probably not supposed to spend that on the competitive drug, just in general, if that makes a lot of sense. So let's look at what we have right now. We have Cadiorenal, which is the one of Spero with RA. They've already been proven very well that that's. We have lower hyperkalemia, almost focused on the 25 milligram lactose is about 12%, you know, uncontrolled in patients, whereas Cadiorenal is about 4.5% size. The less hyperkalemia, minimal impact on blood pressure, if that's actually running, and also limited the rate of kind. Whereas our third number lactose, very good for refractory hypertension. Also reducing albumin area. This is where the discussion is for the reduced albumin area. When that also be considered additions. So we'll dive into the one side first. We have Fidelio Figaro. So the Figaro is the less severe of the two studies. Here ACR around 100, EGFR 45. The Fidelio was with severe patients. But they basically designed these mirror going back to the first graphic, patients or dying from cardiovascular outcomes. So these studies are very similar. It's the primary difference is the primary positive outcome. So in the Figaro, we had the cardiology composite, and the Fidelio, we had the cardiology impairment composite. Still showing pretty good relative risk reduction of about 13 to 18%, which is on the lines of where our pivotal harassing issue study about 13 to 14%. So just as effective roughly as a basis when you started therapy. This is on top, of course, repair, which was your line as so we actually got a study this year. Who would have thought looking at spironolactone, see the effects of CKD, not sponsored by industry, but our British colleagues and also sponsored. So they do have socialized medicine, the National Telephone Service, and they signed a new study. Probably they're thinking that they would find cost of because cheaper spironolactone. Well, they signed it, and it's very impressive. You don't read it under 50 pages long. That all take the recommendation. But they decided the 1:1 ratio, 25 milligram of spironolactone, addition standard repair or standard repair only. Placebo arm. Usually just want to enroll over 2,000 patients. They didn't make it that far from the CY, but still over 1,500 patients are enrolled with a very nice under all called scale of so I believe it's the next is what you're worried if you go in the wrong subject. But did they find no cardiovascular mortality benefits? No what the problem is. In fact, placebo appeared to prove that you can't see, but there is essentially no difference between placebo in this patient population. What did they actually find? Patients rapidly accelerated on CKD progression or GFR decline. They found high rates of dropouts. makes sense because they had high rates of hyperkalemia. So even the study authors, it's just brilliant. This is still got published, right? Because the publication bias here, they're on the results that you're published, many results are very open to. However, in this situation, they outline that the addition of low dose spironolactone provides no particle protection, only increased patient confidence. Pretty strong statement. So now we go over to our targeted therapy. I won't spend too much time on this. This will probably be one of the big discussions coming. But looking at one example of diabetes study here at the bottom, we are strongly recommended individuals. Diabetes, particularly one of the also on top of it. Really good data came out as well. We will dive into the post study. So we have very, very plus data. This is the fourth study in history, and they're all stopped early due to positive outcomes, positive efficacy. 34% relative risk reduction, beautiful positive. We're looking at time of persevering for kidney failure or initiation of replacement therapies or persisting greater 50% reduction in GFR or death from kidney or cardiovascular design. And the leader on this study, brilliant, they designed it so they met statistical superiority. They could go into every set of category on size. A lot of studies you see plots, little boxes, and like, oh, well, here's the subpopulation, which is not tell you because they're not designed adequately. You're going to you can't stay and oh, well, this looks like it only worked in this living population from America. But they designed it so they met it and achieved it. They could apply it across the boards and they get one. Very, very impressive. But when we stop to study early, we take the risk of not being consistent if you have to adjust your change probably. So the statisticians said they had to drop it down to 0.03 instead of 0.05, and they approached that in order to p-value exception low. It was a very, very low likelihood chance at like 0.001 on the coronary composite. Crushed it on cardiovascular composite as well. Looking at an 18% relative risk reduction. And keep in mind on the death one, this sounds very, very impressive because they enrolled very high risk patients. In the placebo arm, just the 2.5 years of study was going 1 out of 6 patients in placebo arm. And that's pretty much like I'm assuming you have high risk. Go back to head ratio of like 600% chance. And so they hit this. It was very impressive for those that are not in the industry working with FDAs and looking at packet inserts. Everything in packet insert, bullet, italics, have to be approved. This is one of the pivotal drivers to why some items 95 got an FDA indication for CAD and prevention of death. Very strong labeling that does not have a filtered approval from FDA. So very, very impressive results, which is why we'll see what happens with the new ADA data update. It could be very depends on how they say cost benefit now into federation of deciding not to focus purely on benefit. Be very intrigued to see those. So the kidney health evaluations is our aim screen. So basically all it requires a full rolling period, EGFR, and their APR. Right here is where the national benchmark is. This is a snapshot from last month over it's right now. We have a little room for improvement, and on the top there, compared to overall for this 20 other so I'm our 800 point. Please utilize that button for diabetes screening for all patients with diabetes. If you have a patient with CKD that don't have that with concentrated patients, please use the combination as RAS vision, vision, and unfortunately they have heart failure. We'll get have the condition. And for those with CKD type 2 that are still progressing, utilize targeted therapies of non-steroidal narrow, non-steroidal MRI, narrow. They're also perhaps should be more getting on their specific independent risk. And I made this graphic too. And then questions. Yeah.
I didn't know about the sorry, it's a position, but it happens in. But that was a. 200 Yes, in the prior round, then you know, if you want to do something.
Would be interesting to see where it goes. That's a good. I'm sorry, I'm not being taught about cancer. It's a facility in which individuals can decide if they want to provide access broader than general or most district. I really hope that ABA, this year, he moves and you where it needs to be covered. That's not the game.
So, we had a contractor. We're gonna be here, reach out, we're gonna have a talk, go through all that. You know, we call them.
Oh, they were my this is probably in trouble, but one of my issues to the day for you know, like last fiscal year, EA was to check out other. So we had almost cut, but like the other only position for years. Their demo shortfall is like $4 billion. So they moved to Congress, the addition of them to become the all those budget development, this one made five on the table. Resulted in $3 billion. We ended the fiscal year by probably. We resulted in both sides, like a good while, really Anthony here. So my pitch yesterday, back from the. I think just that funny thing, right? You know, if you're saying you'll be one of the reception agencies. If you directly correlation extra $800 million for veterans dying, have to be seen by a task to do. But we'll see. That's usually kind of the point. Other questions? With it, long and magnificent. Yeah. Yeah.
Right, that's about that.
I like to see. Well, after some, we're next, which you think, is higher. Yeah, I need to. I'm going to feel. Yeah, you're trying to do some stairs, some other, they were like, we got. Yeah, it's like, everybody, I asked them, it's such a big stuff, we're like. Stone up into the really goes up. Into the. We were going to go meet the council, and all I'm saying is that it's entirely different. I don't want to take this at Brown, I mean, you can serve these orders in the. Even though we're looking at your point and where it's on to get some of the about always make you start like when you got none, better get your permit. I got one just be able to watch out, just watch out, and they're doing it. Hey, we're going to think down some of yours. That's stories that we made on the highest and the lowest, and now it's totally available. And then some very good titles. They just think it's a pay is crazy. So he was I think things in and he said, no, we will talk to the and so he's young and we will study. They're obviously, I think so. So, yeah. But then I saw the other side, I'll see you like this guy. I'm learning that. See this comes why we next to see every moment like when I say consider everything like everything so like I just raise the body I bring it's next to me and I'll work 6 hours I go there every week and you spare you're like, I'm so they would looks like I didn't think that like I've been saying regardless and still see that no, I mean, yes, I have some moment, not really regrets, feel we're getting, but you know, like, I know, you know. Yo, my kids are so 6 and I am first and third grade, so both guys, so this one years. I think it's pretty cool. Yeah. It's cool. Thanks. Well, it's really good to see you. It's touching base. It's growing well. And also good, good place to be. Yeah. And then I heard actually, she also said that we didn't even find it all. But everybody did here. But which I actually really like to make you like this place. I thought about doing something else myself. We're going to something that's the main model. Yeah, all you have to do is make sure that that's the damn thing that can come with the back. Think you're better. She has those connections on the guy. You only need one of my nowadays, I think they're even fun of the HDMI American like do yeah, I'm maybe saying there's two of the perfect. I like to send out, I hope you do on the internet. Yeah, I sent it to Dr. Bruce and Dr. Wagner for the local area. But I would say, I'll pay you better than the place with their guy effectively.
Thanks for waiting. Hey. Hey. This has a microphone. This is what works. Oh my gosh. This is what was working, not that. All they had to do was just do it, kind of what was calling me to. That's what was calling me, I got you were picking up from the computer down here.
Thanks.
You are welcome.